Hi, this is Brian Lomers giving a lecture on the care of patients with diabetes mellitus for medical surgical nursing at the University of Sioux Falls. Learning objectives, we're going to be talking about type 1 and type 2 diabetes, including age of onset, manifestations, and pathophys. We're going to talk about how to care for the patient with diabetes. We're going to talk about evaluating laboratory data regarding diabetes therapies. We're going to talk about identifying nursing priorities, collaborative interventions, and education. So type 1 or type 2 is a major concern that we've got to figure out. Oftentimes with this, we are seeing that type 1 is a little different in that it's a smaller percentage of the population in the United States. And then often they've had a recent viral illness. They've got a family history of autoimmune disorders or of type 1. And that usually that these patients are less than age 30, but it can happen at an older age as well. This manifests an abrupt start without warning, and what you're going to probably see in these patients is polyuria, polydipsia, hunger, weight loss, as that sugar is climbing. So this is an autoimmune destruction of the pancreatic islet cells, and what's causing it is that their body just doesn't have insulin. And so this is going to be, they'll become insulin dependent after this. This varies from type 2, in which type 2 tends to be more of obesity, sedentary lifestyle, hereditary, increased abdominal fat, hypertension, hyperlipidemia, some of your risk factors. Tends to peak later on in age, but can happen much earlier. We are starting to see some of our pediatric patients with type 2 diabetes, and that's awfully sad to me. Manifestations start as pre-diabetics, and usually they don't have any signs and symptoms, but then eventually it goes into thirst, fatigue, blurred vision, and those other changes with that. So what's going on is that there's increased production of glucose, and the body just becomes resistant to the insulin, and it just doesn't work as well as it used to. So subjectively, some of the things that your patients might say is they've got signs and symptoms. We talked about all those polys, as well as frequent infections and family history. Objectively, look at the weight, look at BMI, body fat distribution, age, race, and any signs and symptoms of complications related to diabetes, which I think you all know that there's plenty of those. So in looking at diagnostics, we're looking at some of the lab values for fasting plasma glucose. Normally it should be less than 100, but if it's this, between 126 and it's impaired, or greater than 126 times 2, it would be diabetes. Glucose tolerating test, you're going to see this more in pregnancy, and so you're given 75 grams of glucose over 2 hours and see how much you bump up their sugars. And then hemoglobin A1C, 4 to 6 is normal. If it's greater than 8, that's poor. If it's 6 to 8, then that's increased and can be signs and symptoms of diabetes. Other labs, they might be doing diabetic ketoacidosis, so they might be passing ketones in their urine. They might be having damage to their kidneys and they're leaking some albumin. They might have some glucose in their urine. And so we do want to watch that kidney function with BUN and creatinine. And looking at their clearance of urine output. So nursing priorities, so, potential for injury related to hyperglycemia, impaired wound healing, diabetic neuropathy, diabetic retinopathy, renal function, and then hyperglycemia are all real concerns with this. So if they've got hyperglycemia, so some of the things that we have to watch for is, that they can manage this on their own. So can they do the diet and the sugars and the medications? So some of our intervention is carb counting, and so we'll do these carbs and they can have so much predetermined at the meals, or that they give medications as prescribed based on the amount of carbs that they're eating. Other interventions, so glucose testing, this could be self-monitoring, this could be lab monitoring, this could be self-monitoring glucose, and which is really pretty cool because that will communicate to an insulin pump or just automatically record it, and so that can be a great thing. So Do have to watch for a little exercise intolerance, and they might get hypoglycemic with this, but usually that doesn't happen very frequently with type 2. We do have to watch for retinopathy, make sure that they're wearing proper footwear, and then screen for coronary artery disease. Other interventions would be maintaining optimal weight, health promotion, so checking those sugars, lipids, hemoglobin A1C, regular foot exam, and we'll talk about that here in a little bit, an annual dilated eye exam, and then annual urine for microalbuminuria. Surgical treatment, some have had pancreas transplants of this and that has worked, or islet cell transplants and that has worked. It is not a common thing, but they are working on that, especially as we're talking about stem cells, and hopefully the patient can start growing their own, which would be awesome. All right, trying to prevent harm and peripheral neuropathy. So since they can't feel and they lose sensation with that, we have to be very careful with this, especially with their foot care. And so we really worry about that they might get breakdown that they don't feel about. They might have some rock in their shoe or ill-fitting things that's rubbing, causing irritation, and can cause significant breakdown. So they should look at their feet daily, clean them, avoid walking barefoot, trim the toenails properly. Yes, I know that that's kind of a thing, but oftentimes you have a specialist that will have to trim their toenails, and you want to do it straight across. You don't want to do it around the bend, so to speak. So this foot injury is no joke. It's one of the main complications of diabetes, leading into hospitalization. And so any broken skin increases risk for infection, so they can get septic off of this. So intervention, evaluate the feet, do that filament testing. And so the next slide will show this pretty good, but you're taking monofilament and kind of pushing it and see if they can feel it and if they've got sensation. You just got to push until it bends a little bit, and hopefully you can, they can tell you what toe, where they feel it at. So talked about be careful with the socks and the shoes, but they can also get Charcot, and this is a malformation of their feet related to these peripheral changes and the vascular changes that go along with it. So this is an orthotic type of issue. So, said it before, no walking barefoot, no open-toe sandals, avoiding extreme temps like putting your hand in too hot a bath, touching pots that are too hot but you just don't feel it. And so you got to be careful with that. Get good fitting shoes, no pointed shoes that you can't feel that are squishing your feet. Inspect those feet daily. Apply moisturizer, but not between the toes because it gets too moist and then fungal infections can set in. And then like we said before, cut toenails straight across. Wound care, so that moist wound environment, we said that was not a good thing when you're putting lotion on feet, and so we don't want to do that in between toes. We want to make sure that they're drying their feet well after they shower or take baths, and then we want to promote good skin healing and keep those feet dry and warm. Now, if they do get wounds to that, you're going to see some of the stuff in like wound ostomy care when they're debriding it using enzymes or scraping it off or cutting it off. And then, of course, if they've got wounds with this, we're trying to heal that up as much as possible. The neuropathy, so they can get pins and needles feeling, so the gabapentin, pregabalin are important with this. Tricyclic antidepressants can be working with this. Capsaicin cream can be used. I've heard some results with that, but I haven't seen it as a staple or commonly. And then, of course, stable glucose control is a big thing with this. So, if they've got reduced vision, of course, trying to minimize this, trying to minimize them from having double vision, keep that sugar in check, and try to maintain their vision as long as possible. So, interventions, stabilize blood sugars, big surprise with that one, wear appropriate eyewear, and have good checks at least annually, if not twice a year. And then, adapt things as needed. For kidney disease, we're going to make sure that they have a normal elimination pattern. So, once again, control that tight glycemic index, watch blood pressure, and watch lipids. So if they are on dietary protein restriction or fluid electrolyte restriction, we will manage that. Watch serum creatinine, microalbuminuria, and the BUN. Smoking cessation is always great because atherosclerosis on top of decreased perfusion can be really bad, and it's going to minimize the amount of flow that those kidneys can get. We do want to treat any infection promptly, and of course, we give drug therapy as indicated. Preventing some of the hypoglycemia, so they can have a hypoglycemic response type 1. Realize I've seen this commonly if they're working too hard, overexertion, those kind of situations. So then we have to treat with some sugar. And that can be some of the tabs, it can be D5W, it can be a host of things, but they need some of those carbs. So intervention-wise, monitor the sugars before meals, after meals, at bedtime, and anytime they're symptomatic. We are going to see if there's any drug-related causes for getting hypoglycemia, or if it's exertion-related, and then, of course, we can treat with carbohydrates. Now, a lot of people say, give juice. That's the big thing. Give juice, and that works. That is, fructose is carbohydrates, and it works really rapidly, but the bad thing is it will spike them up. Just like using cake frosting, yes, it is high on carbs, and you will get that sugar up really quickly, but it will spike and then they'll crash again after that. I've heard from some diabetic educators that they prefer milk because the lactose is carbohydrates once again, but it won't cause them to spike up as much. So other treatment modalities, D5W, D50, glucagon, so lots of different ways to treat low blood sugars. Prevention, careful when switching insulin brands. Some of them will change. So some people are very specific to their medications, and so even switching the brands, being on the same type of insulin, but just switching brands might alter how they react to it. Other things we've got to know about is, regular and timing with their food. How much are they taking? What kind of insulin are they giving at that point in time? Alcohol can cause a drop in their sugars. And so we have to be very careful with that. And if they're prone to this, or if they, best practice, they should probably have a medical alert bracelet on or a necklace, and then teach them those manifestations that they could occur with this one. So if they're cold and clammy, they might need some candy. Samoyed effect and the Down phenomenon are real situations that happen that cause people to really have elevated sugars in the morning. And so Down phenomenon is related to the hormones. Samoyed effect is related to some of the hormones, but it's also related to blood sugar. So that's a slight difference between those. So Down phenomenon is more common, but realize that high blood sugar could occur in the morning related to these. So DKA versus HSA. So we'll talk about this more in pediatrics and high acuity. But these are hyperacute states, so in which they get too much sugar, and it goes really badly for them. So they can end up on vents, ICUs, and they tend to be very sick. If they're starting to go into diabetic ketoacidosis or hyperosmolar hyperglycemic states, we want to notify the provider and then treat it and be very aggressive with this one. So we're monitoring sugars, looking for ketones, and we're trying to give the insulin and anti-diabetic agents as prescribed. This can be triggered by illness, so common upper respiratory infections or other infections or stressful events can trigger this. And so other things we can do with this is prevent dehydration by pushing fluids that are sugar-free while awake. If they're hypoglycemic, you might add some sugar to try and replace it. But really what we want to do is just get a lot of hydration in because they'll get dehydrated at the cellular level related to the hyperosmotic state. They do want to continue to eat meals at regular time, adjusting carbs as tolerated, and then call the provider as needed. Community-based care, so teaching self-management as much as possible. assessing physical, cognitive, and emotional limitations related to this and what to do in those situations. And if they're having some signs and symptoms that are disadvantageous, they should work on that and contact people and implement a plan. So we as nurses do need to do in-depth education for these patients, both in the acute care setting and then probably lifelong, and just make sure that they understand some of the main home care management skills that they will need. That concludes this slide. If you have any questions, feel free to contact me.